I'm Abdul Hasib. I'm a consultant pediatrician and I'm the Royal College tutor for Paediatrics, and I'm the neonatal lead as well. And I work with a team of 10 consultant colleagues and ably supported by allied health professionals, senior and specialist nurses, and a wide-ranging experience of junior doctors and pediatric dietitians and pharmacists. Ours is a very large directorate, and we have pediatric department which constitutes the Willow ward and the pediatric assessment unit, and which has close links with the A&E and accepts GP referrals directly. And then we have the outpatient area where we have general pediatric clinics from all our consultants, specialty clinics, and outreach tertiary clinics from visiting consultants from the London hospitals. And we have the largest neonatal unit as a level 1 across the whole of Southeast Coast, more than 5,000 deliveries per year. And we work very closely with the maternity side. Community pediatrics is a separate directorate, but our junior doctors get 1 weekly rotation into community pediatrics as part of their rotation when they learn about managing patients in the outpatient clinics on a community basis.
My name is Pearla Gakwu. I'm one of the members of the team, of the paediatrics team. I'm the F1, so this is my first year in training, and I've just started my job on the paediatrics team. It's the first time they've ever had an F1, and it's quite a supernumerary role, but that's not necessarily a bad thing. There's a lot of teaching opportunities and the team are very supportive. They let me do as much as I feel comfortable doing, but I'm usually with someone else. I'm always observed, and that helps a lot with teaching as well.
My name's Sabina. I'm one of the GP trainees, GPST2. I'm actually based in the community, but for 1 week a month we do acute paediatrics here at Dartford Valley Hospital, and that's so we can get some acute paediatric experience. So when you come to the job, you'd be allocated a week a month, and then this will be incorporated into the rota. Usually we do PAU, Paediatric Assessment Unit, but if needed then we will cover other areas. So far it's been brilliant. The team's really welcoming and supportive, and the consultants are aware that obviously we're only here a week a month, so they make sure that you're comfortable in the role.
So this is Willow Ward. It's the main paediatric ward in the hospital. We have 22 beds here, and the children are aged from 16 and below. Right behind us we've got the paediatric assessment unit as well, so that's where children are assessed, and then if they need to be admitted they can be admitted onto this ward here.
So this is the paediatric assessment unit, and this is where we see patients who have been referred by the GP or A&E. We've got 4 beds and 2 cubicles down here, and we've also got computers where we do our electronic discharge summaries and order bloods and various investigations.
We also have a pre-booked patients who come to pediatric assessment unit, where it could be for blood transfusions, it could be for immunoglobulins, anything planned which doesn't need to go in the ward is taken care of in pediatric assessment unit. And the SHOs, FY1s or junior doctors are always supported. You will have a port of a registrar to call at any point, and if there is any emergencies, we always go to accidental emergency. That's where we see the patients, those who are much more sicker there, stabilize them there, and then transfer them back to the ward.
Handover takes place between 9 and 9:30 in the morning, and then that's followed by the ward round with the consultant. After that, the SHO would be expected to work with the registrar to prioritise the ward jobs, ensuring that discharges ideally are dealt with first to free up some bed space, and especially discharge medications. The SHO would then complete those ward jobs. Usually halfway through the day there's teaching. Then handover is prepared for in the evening, and that happens ideally between 4:30 and 5 o'clock. And the PAU, SHO and registrar would start from 9 o'clock in the morning on PAU, and they'll be seeing any patients who are being brought back for reviews, patients who might be ambulating on antibiotics, and any new referrals either from A&E or from GPs, and any patients who come through A&E who are under the age of 1 will be seen by that team. And then everyone joins handover in the evenings.
Hello, we are in our special care baby unit, which is called Walnut Ward. We have a great team here with supportive consultants and nursing staff. The unit has 22 cots. We look after babies from 31 weeks gestation to above. Behind me here is Dolphin Ward, which is our high dependency area. We also have 3 nurseries, 2 rooming in rooms for parents with ensuite facilities and 2 side rooms which also act as isolation purposes as well. Our main tertiary centres are William Harvey Hospital in Ashford and Medway Maritime Hospital as well. We tend to liaise with them should we need any advice about management, and also our more premature babies who require more intensive care mostly get transferred to Medway Hospital. As well as the facilities on the unit, we also have a treatment room, and we have the postnatal wards called Aspen and Cedar, where babies on transitional care who require antibiotics are looked after, and also the baby checks take place there as well.
So when you're on the special care baby unit, you're looking after the babies, and also you're attending deliveries in the delivery suite and in the obstetric theatre. Things like emergency cesarean section, instrumental deliveries, and when you're called, you'll be told what kind of delivery it is so that you are aware. There's 2 postnatal wards, so you have the Cedar ward and the Aspen ward. Usually for Aspen ward, it's for low-risk pregnancies, and Cedar is more for high-risk pregnancies, but yeah, we do cover both. You also have the birthing centre, and you've got babies there as well, which are very, very low risk.
So as a registrar on the special care baby unit, you lead some of parts of the ward round. You attend all the high risk deliveries in case the baby should need any support when the baby is born. And we also support and supervise the SHOs covering the special care baby unit and the postnatal ward. And we review babies less than 10 days old referred from the emergency department and also from the community with concerns like weight loss, jaundice or poor feeding.
So with handovers, usually if you're on special care, the handover starts at 9 o'clock, and it's usually a team of doctors, a senior sister from special care and the consultant. And it lasts about half an hour usually, and then everybody disperses. And there's also another handover at 4:30 in the afternoon. And also there's a handover at 9 o'clock in the evening. So usually there are 3 handovers during the day.
So we have a very robust and well organized teaching program which is sent out to all trainees in advance. And we have a structure for every Monday for a theme-based teaching which covers the curriculum for the broad range of trainees.
So in terms of learning opportunities, it's all day, if you say to speak. In what handovers we discuss about lots of social concerns that may be there, and you try and understand the basic backgrounds that you and if there is any social input that has to be put in, you have the specialist nurses who will be able to let you know the social details from that end. And when you are in the ward round, the consultants are very helpful and they do teaching on the ward round itself.
There are lots of teaching opportunities. So we do have almost daily teaching, at least 4 times a week. And we do have simulations every month and lots of clinics that you can attend. So there's a varied opportunity of learning here.
We also teach medical students as well who are on their placement with us. Other learning opportunities that we have is the cranial ultrasound scan that we have available on the unit for teaching purposes.
We have teaching pretty much every lunchtime. On Wednesdays I've got my F1 teaching, but every other lunchtime there's usually something that the paediatrics team are running, so that's really helpful as well.
The case-based discussions on the Wednesday are very useful, which is why the case should be identified early. The SHO gets an opportunity to teach on the Friday, themselves. Then Dr. Kumar is the head of audit, so if anybody wanted to be involved in an audit during the rotation, he's the best person to speak to.
We organize deanery meetings or training days for PLEAD days for our pediatric trainees as well. Every Thursday I meet the trainees regularly to get their feedback, to get their comments and to support them in their journey.
In terms of annual leave, we have in the 9-week rolling rota, we have 1 week of fixed annual leave, but it is flexible in a way that if you don't want annual leave, then you can accumulate that and possibly take it in your clinic week, but it has to be within your confined number of days that you are allocated to take.
Of course, our department is a busy department, but it is ably supported by registrars and senior trainees, senior specialist nurses and senior nurses, and consultant of the week both for the pediatric side and the neonatal side. And if I focus now starting with the neonatal side, all the junior doctors get a good induction and simulation for neonatal resuscitation, and they are encouraged and they are ably supported when they attend deliveries in the first few weeks till they gain reasonable competence, and even then we allow them and encourage them to attend delivery room calls and neonatal resus calls with their registrars and consultants. On the pediatric side, because we have close links with A&E, and every work a junior does is supervised by the senior registrar and by the consultants on a regular basis, so that they can ask for opinion and feedback on the patients from the consultants directly.
There are only few hospitals where you have 2 registrars at night and 2 registrars in the evening hours, and that is a very positive thing for us. If we are busy either in special care, lots of admissions, or in A&E, we have other senior person on site to help us.
Yeah, I think it's very, very well supported. I'm never, left to do anything that I don't feel confident or competent to do. It's just about how much I want to push myself.
The paediatric team is so supportive. There's always consultants around who can be called and will come and help at any opportunity. And as an SHO, you're always working alongside a registrar as well. So you're never left on your own. There's always people who are there to support.
Hi, this is Donna.
Hi, this is Claire. And this is Leslie.
We are the play specialists on Willow Ward. We work 7 till 7:30, Monday through to Sunday. We advocate for children and staff. If you do any procedures on children, treatment room or bedside, please come and get us. If you can't see us, you will definitely hear us. We are very loud. Bye!
Bye!
I've enjoyed it very much. Yeah, we have very supportive consultants, very friendly nursing staff, and it's been great. Lots of learning opportunities. So.
I've enjoyed working here a lot, so I've been here for about 8 months now. I've found it really useful preparation for my exams. It's a really, really friendly team. The nurses are really helpful, and there's lots of nurses on the paediatric and the special care side who will help you to do things like cannulas and blood tests, and generally help out when things are too busy.
Yeah, it's been really, really good so far, and it's quite nice because I get to move around from postnates to the main paediatric ward to special care baby unit, and I get to spend some time on clinic as well, so it's very varied.
We look forward to meeting you all, and please ask for help wherever you find it difficult or you feel out of your depth. We are there to make your journey enjoyable and support you all through the way.
This trust is very supportive of our trainees and junior doctors, and hopefully you will experience that as you work with us. We have a busy district general hospital, so you will be busy, but hopefully very supported. In terms of our organization, we have a fairly flat structure of management, which means that access to your senior consultants, to the Director of Medical Education, and to the Chief Executive should not be difficult. But we don't anticipate that you will need it, because you should be very well supported in your departments by clinical supervisors, by educational supervisors, and in lots of the departments we have college tutors and also foundation and GP training program directors. So we don't anticipate that you will feel unsupported. However, if you have any concerns, I would like to make clear to you that you should access any of our support structures, including your supervisors, or failing that, or if that wasn't appropriate, the medical education department, where I or my team would be more than happy to support you. We'd like to welcome you again. Best of luck.